But let me become a bit recursive here and ask the obvious question, which is, so what? If we can't affect the course of the disease, and we're going to discuss whether we can or not, then what difference does it make from a payer's perspective to establish the diagnosis?
Well, think about the course if you have Lyme and you've been misdiagnosed with MS. The opportunity to actually treat and potentially cure because you've missed the diagnosis and now you're on a disease-modifying therapy and agents you really don't need, which may actually make Lyme worse and progressing. And so the consequences, it all hinders on, let's make sure we have confirmation of the diagnosis and then appropriate therapy follows.
I would be beyond the treatment. I mean, we could also bring NMO, neuromyelitis optica, where obviously MS medications may be in part harmful for some MS patients. It's also, people make life choices, patients make life choices if they are diagnosed with multiple sclerosis. They may not have children, they may do things, they may not go for a promotion at their job because of fear of failing. So there are many different issues. I would like to come back to one point. We kind of glossed over, we said CT is useless.
She said CT was useless.
No,
I realize.
Yes.
You're not going to argue for CT.
I'm not going to argue for CT, but I'm going to argue for MRIs that are properly done. Open scanner, upright scanner, low field MRIs are inherently useless. I would like to make a little patch for the consortium of MS Center, minimal criteria what an MS MRI should be. Because very often we look at MRIs that are short of a Rorschach test, where we it could be anything. And so a quality MRI, like a lumbar puncture that is done in the proper way, like a workup that is done in the proper way, is an integral part of at the start.
No test is as useless as the test that doesn't, by design, tell you what you expect it to tell you, right? In other words, if you do an open MRI, if I understand you, or a standing up MRI with insufficient Tesla, and it tells you one thing, throw it away, right? It gives you either a false sense of security.
But then the patient had an MRI and may not be eligible to get another MRI. So it has
right. Well, you want her to disallow the inappropriate MRIs and give you the money for the right ones.
Well, I think this speaks to standardization, and I think that's what Dr. Leist and Dr. Coyle are outlining. And as a payer, I'm comforted by a degree of standardization that gets everyone to a higher level, and confirmation of the diagnosis is the beginning.
All right, well, with all of that, is it worth diagnosing MS early? Let's just put a button on this. Yes? No?
I think so. I mean, obviously, isn't that the point? With disease-modifying treatments, you would hope that you get to these patients early to have a significant impact on that journey.
You have accumulating data that early treatment is key to decrease late disability. Absolutely, all the studies are showing an early treated group is doing better, and you probably have a window of opportunity, ideally to treat within 6 months of the first attack, to really maximize prevention of future disability. Early treatment, in my opinion, is key.
This is an answer that is very much of the 21st century. When I went to medical school, that was a debate. Why even make the diagnosis?
Well, in Merrill's textbook of neurology says one shouldn't burden the patient with the diagnosis of multiple sclerosis because there is nothing to be done. I sometimes think as neurologists we need to look outside of the field and go, for example, to rheumatology, where it says treatment to radiographically silent RA, rheumatoid arthritis, is indicated in a patient with rheumatoid arthritis. So what's good for the joint is probably also good for the noggin, for the brain.